Hey you guys, welcome back. Today we'll be going through the physiology of the heart. Buckle up, it's going to be a long but very important lecture. So let's go through the conduction system really fast. There is going to be the atrioventricular delay, which occurs in the AV node. So that occurs about 100 milliseconds, and that is due, so basic like physiology, due to the reduced amount of gap junctions and the narrower diameters of the fibers, so the action potential won't travel as quickly. So the problem with this is, well, not problem per se. We'll go through the problems of this leg later on, but this is a really important delay because it allows the ventricle to fill. If there is something like a fibrillation where the ventricles contract irregularly or too soon, there's not going to be enough ejection of the blood. So the depolarization occurs, like, remember how the heart is like that, and then there's the septum down the middle. So it goes down the septum, and it goes from the left to the right. And then once it reaches the apex of the heart, it goes up, and then it goes from the endocardium to the epicardium. So it kind of like goes down, up into like an anchor-like motions, and then from the inside out. So the intrinsic firing rate is going to be the highest in the sinoatrial node, of course, because this is the pacemaker of the cell. And it takes about 90 seconds to depolarize the atria. And then the delay at the AV node is going to be 100 milliseconds, and that's going to be the slowest intrinsic firing rate. And then in heart damage, if the sinoatrial node fails, the AV node will like take its place and work as the second pacemaker. And then the velocity is going to be the fastest in the Purkinje fibers, but it has the slowest rate of firing. Why is that? So it needs to spread the action potential very quickly in order for the ventricles to contract in sync, because of course there's like a lot more surface area to contract because the ventricles are larger than the atria. And the rate of firing has to be slow and steady in order for the entire ventricle to contract. So we start here. This is the depolarization. This is the P wave. We'll get through that later. But first, the atria is sends the action potential from the SA node. SA node sends information across this atria septum, across into the Bachmann's bundle for both to contract at the same time. And then while that's contracting, it's being delayed at the AV node. And then the AV node sends the action potential down the bundle fibers, and then from the bundle fibers it reaches the Purkinje fibers down here at the apex. Purkinje depolarizes, keeps depolarizing. Finally, the ventricles squeeze, and then there is going to be the repolarization, and then the action potential has been basically reset, and then we can do it all over again. Okay, so ECG or EKG, these terms are used interchangeably, is not a cardiac action potential. This is not one cell. This is going to be measuring the conduction system of the whole heart, the way the syncytium work together, and the electrical activity is going to be spread through the body fluids, and then the leads pick it up. They are used to find these conduction issues, and we'll go through all of this later, but this is the standard like EKG presentation. So remember when I said that the heart is autorhythmic but has some form of input from the like sympathetic and parasympathetic nervous systems? This is because the sympathetic has the beta 1 adrenergic receptors on the heart. And this is really important to know. Beta 1 is going to be specific for the heart. And that increases the chronotropic, the dromotropic, and the ionotropic effects. So this increases the heart rate, the contractility, and the action potential. So the parasympathetic is going to be a different receptor, of course, makes sense. It's going to be an M2 muscarinic receptor. And that's going to be the opposite, basically. And except for in the atria, it decreases the ionotropic effect only in the atria. And the parasympathetic is going to prolong phase 4 and phase 0, and we will get to that. So, what is the parasympathetic? That's generally the vagus nerves. And then the sympathetic is going to go like straight through the like cervical ganglion. Okay, so the positive ionotropic effects. So it's going to increase the heart rate along with the afterload, and the vagus nerve is going to be inhibited, and catecholamines are basically going to start it all. Norepinephrine will stimulate the beta 1, remember beta 1, receptors, and then from there, the GS protein will activate the adenylyl cyclase, and then from there, it's going to activate protein kinase K, and then that kind of allows the contractility to occur. But ATP converts CAMP, which can, of course, activates the protein kinase, phosphorylates troponin. So with the phosphorylated troponin can bind to the calcium that's going to be influxed. It's going to be influxed because it is released from the sarcoplasmic reticulum and the sarcolemma. And calcium is going to be used for the plateau phase in order for the heart to contract. A drug called phospholambin will stimulate the calcium ATPase in order to relax. So the ATPase will like remove the calcium and allow the troponin to slide back into place. Okay, so the opposite effect, parasympathetic activation is going to increase it. Heart rate's going to decrease, and afterload is also going to decrease. So the parasympathetic stimulation activates the M2 receptors, and it does so by decrease the duration of the action potential, and decrease the calcium channel influx during the plateau. So plateau is going to be shorter too, and all of that leads to the force of contractility to be decreased. So the ionotropic state is basically the contractility of the heart. Okay, so the leads of the EKG or ECG is going to be usually in Einthoven's triangle. So there's going to be a lead on the right arm, the left arm, and the left leg. And there's a couple different leads that you can use. A unipolar, where there is going to be no active leads, while in the bipolar, there's going to be active leads conducting. And then depolarization goes from an action potential, from an active electrode, and that will cause a positive deflection. Depolarization away will make a negative deflection, and that shows as like peaks in the EKG. Positive is going to go up, negative is going to go down. And the standard bipolar leads are going to be used to see the coronal view of the heart, so that's going to be the Einthoven's triangle. And from there, the lead in the arm is usually like going to be positive, and then the lead 2 is going to be in the leg, which is also positive, and then the lead 3 into the right arm could be either positive or negative because the way it conducts. So it goes from electricity goes from minus to plus. So from lead 1 to lead 2, it goes from the left to the right, and then from lead 2 to lead 3, it's going to be this is going to be the left, my left, their right, down to the left leg. Kind of important to know that. Sorry, don't be like me and mix it up. And that kind of gives you that coronal view. In the other scenario, there's going to be augmented unipolar limb leads. So basically that means like a couple of the limb leads are going to be active while one is not. Not really that important to know, except for the right arm is going to be positive, and then the left leg is going to be negative, and then the left arm is going to be negative, and the process is the same. Electricity will travel from like negative to positive, and that's what the electrodes will pick up. And so here it says that the leads will see the heart from the angle of this view, and that's going to just basically read how well the heart is contracting. And then we're going to go into these. The unipolar chest leads are like the most commonly used, so there's going to be 6 leads. Of course, from V1 to V6, and that's around the 4th through the 6th intercostal space. These don't actually conduct anything. This is just all positive leads. And this will measure the heart in the transverse plane versus the corona plane. So this is the more like, standard, traditional looking EKG. Okay, so how do we read this thing, right? So the P wave is going to show the atrial depolarization. This is when the upstroke occurs, the atria contract. The PR interval is going to be the entire AV node conduction velocity. The QRS complex is going to be the ventricular depolarization, and when the atria repolarize, it should be in the QRS area, but since the QRS of the ventricular depolarization is so much more massive than the atrial repolarization, it's buried. The ST interval is going to be the plateau phase, or ST segment is going to be plateau phase, and that's when the ventricles contract. And then the T wave is going to be the ventricular repolarization. The QT interval is the entire period of ventricular systole from the ventricular isovolumetric contraction all the way to isovolumetric relaxation. Isovolumetric is basically like there's no change in the volume. It's isovolumetric, right? But the heart muscle is just starting to contract or just starting to relax. So the heights of the peak correlate to the strength of contraction. Higher the peak, stronger the contraction. Okay, hyperparathyroidism is also detected using the EKGs because the high calcium level. So hypercalcemia, there's going to be a shortened, there's going to be a shortened QT interval, and that's going to be the opposite in hypocalcemia. So hypocalcemia, QT is prolonged. And let's just look at these for a second. So here, it's like you can't even tell that there's a QT interval at all. It's so much shortened. So like let's go down here to the augmented leads. Like you can't even see anything. So we're not going to worry about this quite yet. But as you can see, this patient has hyperthyroidism. So there's going to be high calcium. Let's see, in this person, let's see, here's QRS. Where's our T waves? Oh man, it's all the way over here. Here's your P wave, QRS, P. No, I'm sorry, this is a T. All right, let's see. Don't worry about this one. Let's see the second lead. And QRS, little bump is T, same thing. So this person is going to be suffering from hypocalcemia because the QT interval is so much more prolonged. Why is that? It's because the potassium channels function is going to be reduced due to the prolonged plateau. And the prolonged plateau is just because, there's just not enough calcium. And it takes longer to reuptake. Okay, so mean electrical axis. I know like physiology professors kind of go ham with this, but honestly, it's not that important to know besides these values. So normal is minus 30 to 90. Right axis deviation is from 90 to 180. Left axis is from negative 30 to negative 90. And the extreme axis or the northwest axis is going to be from 180 to minus 90, but that is so rare. We're not at that point in medical school to really be concerned with this quite yet. If you want to be a cardiologist, by all means, go ahead and study this up. But in order to just kind of keep everything in, mind as of now without overwhelming your poor brain, let's just concentrate on these things. So, why are the deviations important? It's because the deviation will occur due to ventricular thickening, heart blocks, or heart attacks. And normally there is some deviation, so don't be too worried whenever you see like a minor deviation, whenever a patient is starting to take deep breaths. And you also have to keep in mind people who are obese or pregnant, because the heart has to beat a little bit harder and it deviates to the left due to the rising of the liver in order to compensate for the stomach and for the growing baby. Okay, right axis deviation. So it's going to show up because of the right bundle branch block and the left posterior fascicle, which is a part of the left anterior the veins or artery. I'm sorry. That's usually caused by pulmonary stenosis or an atrioventricular defect. That could be like a patent foraminal but what's more important, know this. So right axis deviation due to the right bundle branch block and right posterior fascicle, and it's caused by pulmonary stenosis in most cases. And there's going to be right ventricular hypertrophy. And how do we read this, right? So it's going to be in limb or the lead one, it's going to be a downstroke. Should not be a downstroke, should be positive. But there's going to be that deflection. In the second lead, there's going to be a positive upstroke. And in the third lead, there's also a positive upstroke. So that is kind of like the definitive the right axis deviation. So here in another one, here's going to be like I said, lead 1 is down, and then lead 2 is up. But here, as it travels down in the AVL, so remember lead 1 is left arm, there's going to be it just kind of goes over, it correlates. So in lead 2, there's an up, AVF is up, and in lead 3, it's up. And then QRS is, this is just a summary. QRS is going to be up in the lead 3 and the AVF, while it is down in lead 1. But important to know, lead 2 is also up. So left axis deviation is due to the left bundle branch block. And it's like a little mnemonic. It's a left anterior hemiblock, so it's like left axis deviation, left bundle branch block, left anterior hemiblock. Caused by aortic stenosis, problematic. Obesity, also problematic. Pregnant women, which is going to be transient. And left ventricular hypertrophy, which has a thing to do with aortic stenosis. So let's read the EKG. So in lead 1, unlike the other time, this is going to be up. And then the QRS is going to be up. In lead 2, QRS is going to be down, down reflection, down reflection. So as you can see here, QR in the lateral leads, or lead 1 is up, AVL is up, down in lead 2, down in lead 3, along with AVF. So important to keep these in mind and commit them to memory. Okay, so there's a couple different nodal blocks. The AV block is going to be interruption at the atrioventricular node, along with the bundle His or the bundle branches itself. It is going to be shown as very narrow QRS complexes. Infranodal blocks are going to be either above or below the bundle His, and unlike the above, it's going to make a wide QRS complex. And then the distal AV node block is problematic because that can progress to a complete heart block. So look, the QRS is narrow here, Q is actually kind of small here, while here QRS is so much wider. Look how wide it is. So let's look at limb 1 is pretty useful right here. Wide. Okay, so how to measure heart rate? You can count the blocks from each R peaks, and then divide 1500 by the number of blocks to find the heart rate. Or you can, some textbooks do this. I find it a little bit harder. You can divide 60 by the blocks from the R to R in seconds, but you have to convert the blocks because each block is 0.04 seconds. So normal R to R distance interval should be about 20 blocks or 0.8 seconds. And a normal PR interval should about like 0.12 to 0.2. A normal QRS is 0.08 to 0.1. And normal QT is 0.4 to 0.43. These are somewhat important to note. I don't think you need to like really keep it in, put it into memory quite yet, besides the normal R to R, about 20 blocks. Okay, so here's the fun stuff. Cardiac arrhythmias. I'm going to save that for the next lecture because this one is a little bit long. So keep studying and good luck.